Good evening, everybody. Thank you very much for the invitation. Thank you for the introduction. Can you hear me like this, or I need to hold it? You can? Great. So today I'm going to briefly present the work we do at Loyola regarding intraoperative radiation for pancreas cancer. As you all know, pancreas cancer is a highly lethal malignancy. It accounts for the third leading cause of cancer-related death in the US, fourth in Europe. It is projected in 10 years to be the second leading cause of death. Um, Surgical resection remains the main potential curative treatment. However, it's not usually achievable. Only 15 to 20% of patients present as a surgical candidates. And while we all believe that it is a systemic disease and distant mets is the primary cause of death in pancreas cancer, local recurrence is a problem. There was an intriguing study from Johns Hopkins, and 30% of patients with locally advanced pancreas cancer died from local disease without an evidence of distant metastasis. So local control is really an issue here. In every study pattern of failure for pancreas cancer, at least 50% of the patients, if not more, experienced local recurrence, whether without distant metastatic disease. In an NCDB analysis, R1 resection or positive margin after surgery was a predictor of poor survival, regardless of the stage of the patient or any adjuvant therapy received. Adjuvant chemotherapy and treatment in academic centers with high volume patients improved the control. So there has been always some attempts to improve local control, incorporating radiation therapy after chemotherapy, primitive chemotherapy in the old days for locally advanced unresectable pancreas cancer. Lab 07 was a study, 2x2 study, randomization of locally advanced pancreatic cancer patients to either gemcitabine or gem plus erlotinib, and then whether without radiation therapy. It was a negative study, as we all know. However, we learned that gem alone is not enough in pancreas cancer, and erlotinib did not work. Radiation dose at 50.4 did not help much. It was very well tolerated without too much toxicities, but you would question if it was of any benefit really. And maybe the way to go is escalated radiation therapy. And definitely we need better systemic therapy than single agent gemcitabine. So what about the adjuvant setting? We know that the addition of Xeloda or capecitabine to gemcitabine provides some modest increase in the survival. However, something that is kind of consistent in most of these studies is that when patients go for surgery, the likelihood of R1 resection or positive margin after resection is very high. It ranges anywhere from 40 to 60%, which is, I think, unlike any other tumor sites we are treating. It's not commonly seen that you will send a patient to surgery expecting that 1 in 2 will come back with positive margin. And then there was the FOLFIRINOX protocol for these, which is gemcitabine versus FOLFIRINOX. Positive study. We have never seen a median survival in the 50-month range, which was great. However, gemcitabine 2 did a very good job, 35 months, which is kind of unheard of in the prior gem-only studies. So you would question if there was some selection bias selecting the fittest and best patients for this study, especially when you know that pretty much 77 centers included in this study. And again, 40% of the patients had positive margin in this study. That's again a lot. Plus, adjuvant radiotherapy in pancreas cancer comes with a lot of challenges. Approximately 10 to 20% of patients who we would think they are surgical candidates, they will go to surgery, and for whatever reason, they will not be able to get a resection. Exploratory laparotomy also come with some quality of life problems, mortality, morbidity, delays in systemic chemotherapy, and many patients are not able to recover within the 12 weeks, which we know is ideal and optimal to start adjuvant chemotherapy after surgery. Recurrence happen within 6 months after surgery, and I know in most of our practices what we do is that we start with adjuvant chemotherapy, and then before we even consider radiation for those at higher risk, we will like do a new workup and make sure the patient is not already metastatic before offering any local therapy after adjuvant chemotherapy. So what about if we start with neoadjuvant therapy to try to improve the outcomes, maybe minimize the likelihood of R1 resection? So this is a study by my colleague and friend Bill Small. He was back then at Northwestern many years ago. Preventive study, just wanted to kind of visibility study to see if it's safe to provide like gemcitabine and radiation therapy to the gross tumor only. So it was a very tight, small field of radiation before sending the patients to surgery, if any. The outcome was not great. Like, as you can see here, the overall response was only like 5%, only 2 patients responded. But it was simple study with gemcitabine. It was shown that the toxicity was very acceptable in this cohort. Again, primitive planning back then, many years ago. And then there was a meta-analysis showing that neoadjuvant therapy actually helps. The median overall survival by intent to treat is longer. The difference was larger among patients who make it to surgery. So we still know that surgery is essential in pancreas cancer. R0 resection was higher when you adopt some neoadjuvant therapy. And the likelihood of N positive or not positive disease is less. And then there was the pre-OPANC study, which is a preoperative chemoradiotherapy study comparing upfront surgery to gemcitabine, radiation plus gem, and surgery, and then more adjuvant gemcitabine. Pretty much this is the protocol of Dr. Small's study that I mentioned earlier. The study initially did not show the overall survival. Overall survival by intent to treat was not significant. However, R0 resection rate was better. Adding radiation associated with significantly improved overall survival in the patient who were able to make it to surgery, and it did improve disease-free survival, local control, perineural invasion, LVI, positive note. So you name it, but it did not meet the survival endpoint. Everybody against radiation therapy was very excited about this, but a couple of years later, it was published recently this year in JCO, and there was a survival benefit on the long-term follow-up. So it made an overall survival benefit for neoadjuvant chemoradiation. Again, remember, they are using gemcitabine, so that is not the current standard optimal systemic therapy, right? So you don't know if it was FOLFIRINOX. First, if the patient would be able to get radiation, because FOLFIRINOX is a very tough protocol. And second, if that would help. We will go through this in the future. But now they are planning pre-OPANC 2, which is neoadjuvant FOLFIRINOX, then surgery, compared to the winning arm of pre-OPANC. I don't think that's fair for radiation because we know that FOLFIRINOX anyways work better than gemcitabine, so I can predict the results of this study before it's even run. So I'm not sure that's the best study to run in support of radiation therapy. But anyways, it is in planning. In the locally advanced, so those were like borderline resectable and resectable patients. In the locally advanced, CONCO 07 was a study comparing chemotherapy, more chemo or chemoradiation than assessed for surgery. So you start with induction chemotherapy. 70% of the patients were able to randomize to the second phase, which is either chemoradiation or chemotherapy only. And of those, approximately 30% made it to surgery. Disease-free survival, overall survival were significantly better again for those patients who were able to get R0 resection. The endpoint of the study was initially overall survival. However, they had some slow accrual, and then they had to switch that to R0 resection. While addition of radiation therapy did not increase significantly the R0 resection, it was only in the circumferential margin when it was significantly different. And there are many single institution study assessing chemo and then surgery versus chemo, radiation, surgery with very reasonable outcomes. So basically, radiation therapy improve in systemic therapy with the good results we are seeing now from FOLFIRINOX. The need for local control is real. We really need to optimize the local control of those patients because it have consequences. For those of you who treat pancreas cancer, you can see if the patient is during the end of life having significant local control with biliary obstruction, with pain, with bleeding, it's a terrible end of life situation, plus the pain, of course. And definitely R1 resection or positive margin significantly impact survival right now. So there was the Alliance 02-1101, which was a visibility study. You just wanted to see if they are able to accrue patients in this complex cohort to FOLFIRINOX, restage, chemoradiation, surgery, and then gemcitabine. The study met the criteria. They were able to enroll patients for this study, which led to 02-1501 study, which was kind of an interesting study. So it's 8 cycles of FOLFIRINOX or 7 cycles of FOLFIRINOX, and then hypofractionated or SPRT, utilizing lower than what we would usually use dose of radiation. The primary endpoint was 18 months overall survival. Secondary endpoint is all what you can see here. However, when they planned the study, they decided that there will be an interim analysis or planning. So after 30 patients in each arm, if 11 or less are not able to get R0 resection, we should shut down this arm, thinking that they are going to shut down the chemotherapy arm most likely. That was initially actually the thought. However, and radiation was very I wouldn't say suboptimal, but less than what we use right now. So for SPRT, it's 33 to 40 gray in 5 fractions. I think Dr. Henke and I now are in the 50 gray range, which I think works much better. We are blessed to have an access to MRI-guided technology, so which helps us to do this. Or hypofractionated 25 and 5, which is really meaningless for us. So that's a big critique that actually made the arm to close is actually the radiation arm. So the losing arm here after 30 patients in the interim analysis with the radiation arm, to their surprise, less than 11 patients had R0 resection, and they just continued on the chemotherapy only arm. 18 months rate, of course, was much better, but you can imagine the difference in number of patients too. So it's hard to conclude anything from this study. But basically, it makes it clear that this is a systemic disease and good systemic therapy is important and essential. And I hate to say that, but many times we believe as radiation oncologists that radiation is the way to cure patients. Maybe in this disease we should complement our medical oncology colleague and say that, yeah, FOLFIRINOX is important, and we should find a way to incorporate radiation therapy, either SPRT or intraoperative radiation, without interrupting the course of chemotherapy, which is the essential course here. We also know that dose escalation really matters in pancreas cancer. It might even impact survival. So this is an intriguing retrospective study from MD Anderson, and what they said, they looked at 200 patients of locally advanced pancreas cancer. And for those who they had significant decent distance between the target and the luminal organ, more than 1 cm, they were able to escalate the dose. And then they wanted to check. Those were the different protocols, anywhere from 50 and 5, 60 and 10, 67 and 15. Those are the commonly used ones right now. If escalating the dose, increasing the biologically equivalent dose of radiation would impact survival in a retrospective manner, and it did. So the overall survival at 2 years was actually doubled by this, and at 3 years still like tripled. So we know if it's safe, if you are able to do it, actually even in like conventional fractionation, if you elect a protocol like 67.5 and 15, which is really doable and relatively safer than SPRT if you don't have the infrastructure, that's something that you should consider. Another proof in a prospective manner. So this study was presented by Dr. Parikh in Astro 3 weeks ago. This is the first MRI-guided prospective phase 2 study for borderline or locally advanced pancreas cancer utilizing 50 gram 5 fraction. And as you can see here, the primary endpoint was really a toxicity, GI toxicity in these patients with dose escalation. It was multi-institutional study, phase 2. Overall survival at 1 year was 93%, 18 months was 75%. Of course, it was better in the borderline resectable compared to the locally advanced, but still, those are numbers that are great compared to historical controls. And the most important part, it was safe. So the associated toxicity was not, I believe they did not have any grade 4 or grade 5 toxicity, right? And they concluded that it is feasible and safe with MRI guidance to escalate the dose of radiation. And now they are planning lab applet, which is a phase 3 study. and locally advanced pancreatic cancer, so not including borderline anymore, but in locally advanced pancreatic cancer, standard of care either for Forinox or Gem-Abraxane, which is what we usually would use in the US, and then you randomize to whatever standard of care you do or SPRT. So again, not interrupting chemotherapy, not interrupting what you guys do, and then try to add on top some local control if the patient remain without systemic metastatic disease. There are many single institution study, but I still believe if you are able to safely escalate the dose, then you get best results, at least with local control. We submitted our data to Astro this year, and in my institution, I believe we treated 32 patients, all of them 50 gram, 5 fraction, and we never had any grade 4 or 5 toxicity. We had a couple with grade 3, and the majority, I would say only 10 or 20%, had some epigastric pain and discomfort, which was chronic but not bad. They rank it like 3 or 4 over 10, nothing more than that. So we have to be very careful here too, that just treating the tumor might not be very helpful. So when I started, at least in our institution, we started with treating only the gross tumor, similar to Bill Small study and the pre-OPANC study. But then there was a couple of reports coming from Cincinnati and MD Anderson showing that when you treat only the cancer and ignore the nodal areas, there is a higher likelihood of failure. So actually in the study from Cincinnati, in the initial group, when they treated only the tumors, they had 80% local recurrence. And then by including an elective nodal irradiation volume, the recurrence went down to 50%. Those are higher than what we do, likely because of the 33 gram 5 fractions, again, low dose of radiation. But actually, when we started, I had volumes like this. Now I would have an elective nodal volume around it. And that would include usually the celiac and superior mesenteric nodal group. I would prescribe 50 gray to the GTV, the gross disease, anywhere from 30 to 35 gray to the elective nodal volume. Sometimes they go down to 25 if the anatomy is not favorable. I think that's enough for microscopic disease, all in 5 fractions. Every other day or twice weekly. Yeah. So radiation dose escalation, what is the problem, especially like ViewRay or like MRI guidance, elector ViewRay, is not readily visible where you can get access to everywhere. So escalation is not, it is very challenging. It is a very busy area in the body, right? You have tons of organs at risk around it. So there are a lot of setup uncertainties. Actually localizing the tumor is tough. We know that even after neoadjuvant chemotherapy, radiology and CAT scans, you name it, whatever you use, maybe MRI betas would be better, but they are not reliable in assessing if the patient now is resectable or not. There is enough evidence to support that. So to identify where is your tumor and aim at the tumor is really very challenging, especially if you do not have an MRI. There are tons of nearby organs at risk that moves every day. I explained that yesterday in my presentation. Controlling the breathing and respiratory management of the motion is challenging. You ask the patient to hold their breath. They are very frail. They might not be able to do that for a long time. Putting some compression on the abdomen or abdominal compression is very inconvenient. They are already in pain. It is really challenging to do all of this. And I don't know if I should say that or not. Some people, myself included, are now staying away from preoperative SPRT because we are concerned about some surgical morbidity. There is no data to support that, but just talking to our own surgeon and some other couple of surgeons and some other institution, I would not now offer SPRT in the preoperative setting if the patient is still a candidate for surgery. In such case, I will follow pre-OPANC protocol or something like fractionated over 15 fraction instead of SPRT. But dose escalation works, especially in locally advanced patients. So I totally agree on the lab ablate design that I think this should be the cohort of patients that you should aim for when you consider SPRT. So for pancreas cancer, I know we are not yet even in the IRT section, but for pancreas cancer, modern chemotherapy protocol resulted in an unprecedented outcomes. You got median survival of 50 months right now plus. We should always get the patient to surgery whenever R0 resection is possible. We should always aim for R0 resection if we can. We should not delay or interrupt systemic therapy even for radiation therapy. So, you know, our theory at Loyola, is there any way to give the full course of chemotherapy, do not interrupt the protocol, take the patient to surgery, and then think about something similar to what we have done in breast cancer, right? With risk-adapted IORT with or without whole breast radiation after. So risk-adapted radiation for pancreas cancer. Um, so, and there is a couple, before we go to this, there is a couple of reports, one from Milan, from Italy. Patients, 127 patients went for surgery plus IORT, and they compared those to historical patients who went only for surgery. So IORT is intraoperative radiation therapy, and they used intraoperative electron radiation therapy. So their target was celiac axis, superior mesenteric artery, and the edge of the pancreatic stump. And just to imagine how this happened, the patient will have a Whipple surgery. The patient will be in the OR, and then they will transport the patient through the corridors of the hospital in the elevator while his abdomen is opened into the radiation suite. And no, not electrons, not for electrons. That's an electron. So electrons, you need a linear accelerator, and that's in the Department of Radiation Oncology. We do it in the OR. That's a different story. We're going to come to this, but that was intraoperative electron radiation therapy, and you put a cylinder of a linear accelerator. You identify the area. You can imagine just by thinking about it how difficult is that, right? And then you send the patient back to the OR to continue surgery. But they did it in Japan and Italy. I'm going to present the Japanese data too. And then after surgery, a few of those patients also had adjuvant radiation therapy. And they used like older chemotherapy protocols. They claimed that this did not impact the morbidity or mortality of the patients by getting them into the radiation suite and putting them back. It did work well in the stage 1 and 2 patients, so it actually improved time to local failure, time to failure, and overall survival. However, it impacted only local control in the more advanced stages, likely because those patients already had some microscopic or metastatic disease up front, so it did not impact the survival. But it like, if you can look at the curves here, it looks really impressive. Similar data came from Japan, again using intraoperative electron radiation therapy. 25 gray, single fraction, and then patients also received radiation therapy thereafter. 2-year local control is 83%, which is very decent, and overall survival 42% at 2 years, which is reasonable for pancreas cancer with like older chemotherapy. So challenges of intraoperative electron radiation therapies. First, it needs specific shielding, approved operating room, which is unlikely that you will have a linear accelerator in an operating room equipped to do a Whipple surgery. So most of the time you will have to move the patient from the surgery suite to the radiation linear accelerator room and send them back, which I don't think that is visible in many institutions, ours included. Also, like from a physics standpoint, and Dr. Price will be better explaining this, but the scatter of X-rays from electrons would be not optimal compared to photon beam or low kV, which is what we use in our institution. So what we use in our institution is a low kilovoltage intraoperative radiation machine, which is mobile, so we can take it to the OR. It comes with different applicators. So we usually use needle for vertebroplasty or kyphoplasty. That's when there is pain in the spine mets, we go and do that. We use a spherical applicator mostly in lumpectomy, but now we are using it also in rectal cancer. We use surface and flat applicator for pancreas cancer. And the way it works, we will be ready before surgery. The surgeon will talk to me, will identify where exactly he thinks this will be an R1 resection area. We'll be on standby. We'll wait how the surgery go, and if they have higher likelihood of R1 resection in certain area, which is likely will be the stump, plus or minus the nodal area around it, we will give on average anywhere from 10 to 20 gray single fraction, which will take approximately 20 to 30 minutes. We'll do that within the context of phase 1 studies that I'm going to show today. And we have different sizes of applicators. One of the questions, University of Virginia were contacting us because they wanted to start their program, and they said, we think that we will need to cover more than 6 centimeter area. And the answer was, then don't do it. Like, if you think you have more than 6 centimeter of positive margin area, actually you shouldn't have taken the patient to surgery up front. but IRT wouldn't help. The largest applicator is 6 cm. So this is our phase 1 study. I'm the PI of this study. It is a prospective study, dose escalation. So we started with the 10 gray. We finished that. We finished the 15. Now we are in the 20 gray. Initially, when we designed this study, it was for upfront resectable patient. No neoadjuvant chemotherapy were allowed. We submitted an amendment because right now, I don't even remember the last patient in our institution who goes straight for surgery. Most patients will start with chemotherapy first, even if we think they are surgical candidates. We believe that neoadjuvant chemotherapy is playing a major role right now, and that's our standard policy. So we'll start with chemotherapy, and we prescribe to 2 millimeter depth, and it is a risk stratified adjuvant chemoradiation after, depend on the institutional standard. For the interest of time, I don't think we need to just standard. The primary objective is it is a dose limiting toxicity. So there is an evaluation after each point. So there was no issues after 10 gray, neither 15 gray. Now we are in the 20 gray. And as you have seen here, the Japanese data is like 25 gray was safe. So actually we are a couple of steps behind them in this. Inclusion criteria: pancreatic adenocarcinoma, performance status should be decent, resectable or borderline resectable disease, stage 1 to 3, no prior history of malignancies. And again, our first exclusion criteria: if you have a very large area, larger than the applicators we have, those patients are not candidates for the study. Patients who have received neoadjuvant. No, it's a judgment from the surgeon, really. We do not do frozen section there. It's just whatever the surgeon would think during the surgery. Yeah.
You don't consider radiation?
No, not with intraoperative radiation. Like, we aim at the celiac and superior mesenteric stump area, but that would definitely be within 2 or 3 centimeters. So this area is not a problem. Sometimes when they try to cut through the tumor or get the tumor out with like the entire duodenal stump, there is a larger area that he thinks like there is some adhesions or whatsoever, and they think like, I need to radiate a larger area. We have not encountered that in any of the 6 patients we treated so far, or 8 patients. But others did, so in other institutions. So it is an exclusion criteria. So again, 10, 15, and then 20. And now we're planning for a phase 2 study, multi-center study, which is risk adapted. So neoadjuvant chemotherapy takes the patient to surgery, radiation therapy, likely in the range of 15 to 20 gray, and then we'll decide on adjuvant external beam radiation therapy if need to. So in summary, systemic therapy resulted in unprecedented improvement in survival, comes with the limitation of 40 to 60% R1 resection and up to 30% deaths from local recurrence. Improved systemic therapy dictated the need for local control. R1 resection limits the progress made by systemic therapy and decreased survival. Local recurrence remains a problem. Radiation therapy improves local control, increased likelihood of R0 resection, and likely improve quality of life by improving the end-of-life situation for those patients. Timing and dose of radiation therapy are still to be explored and optimized. Radiation therapy dose escalation seems to provide better outcomes if technically visible. Delaying or interrupting chemotherapy to offer radiation therapy might negatively impact treatment outcomes. And low KV IORT to be followed by risk stratified adjuvant chemoradiation might be a solution to optimize local control and avoid risk associated with chemotherapy delay or interruption. And I would like to thank our team at Loyola University in Chicago, and I think I'm done with that.
Thank you, Dr. Tamer, and also we will keep questions till the end of the session. And now it is time for Dr. Endrin Kitty, and his topic is about applied physical topics regarding MR guided radiation therapy or SBRT. Dr. Kitty. Dr. Kitty? Dr. Kitty, he's online?
I think that's virtual.
Virtual? Mm. Dr. Kitty, you're online with us? اخواننا بتوع الاي تي. الاي تي معانا؟ هو مش اونلاين؟ مش اونلاين. طب احنا دلوقتي يبقى it is time for our questions. Any question? Yes.
Thank you for this presentation. My question is for Dr. Michel.
Dr. Michel.
Yes, I have a question on your presentation. The trend today is to escalate the treatment, the intensification for HPV negative patients or pharyngeal cancer. And we had the results of using immunotherapy with avelumab, which was negative. And we are waiting for the pembrolizumab result, combination with concurrent chemo. Now, my question is, do we have an idea why the combination concurrent chemo and immunotherapy doesn't work? This is my first question. And the second question derives